Hi friends, so in this video we shall be covering the various type of skin cancer. So let's begin with the discussion of the first type of skin cancer, which is basal cell carcinoma. Basal cell carcinoma is your most common skin cancer. It is a slow growing and locally invasive cancer. Now, it is a malignant tumor of the pleuropotential epithelial cell which arises from the basal epidermis and hair follicles. The strongest predisposing factor for your basal cell carcinoma is your ultraviolet radiation. The age group commonly affected includes your elderly and middle age, and around 95% occur between 40 to 80 years of age group. It is more common in male compared to female. Then metastasis is very rare in your basal cell carcinoma. The various predisposing factors for your basal cell carcinoma include your arsenic compounds, coal tar, aromatic hydrocarbons, ionizing radiation, and your genetic cancer syndromes. There are no precursor lesions involved in basal cell carcinoma. Now, mutation in your hedgehog signaling pathway occurs in approximately 90% of the patients, right? And the development is proportional to the initial dose of carcinogen, and it is not related to the duration of exposure. And the various types of your basal cell carcinoma can be classified as localized and generalized. In localized, we have your nodular and nodulocystic variant, the cystic variant, the pigmented variant, and the nevoid variant. The nodular and the nodulocystic are your most common variants. In generalized, we have your superficial and infiltrative types, where superficial includes your multifocal and superficial spreading, whereas infiltrative type includes your morphic, ispic, and cicatrizing type. The microscopic finding includes the characteristic ovoid cells in nest with a single palisading layer. So this is the microscopic finding found in your basal cell carcinoma. And in basal cell carcinoma, it is the only outer layer that is actively dividing, as a result of which the tumor growth rate is slower, and the incompletely excised lesions tend to be more aggressive hence, right. The morphic basal cell carcinoma synthesize your type 4 collagenase. Now, because of this variant spreads rapidly, right. Now, these are few of the clinical images which have been taken from your textbook of Bailey and Love. So, if you see your images over here, so you have this nodulocystic variant of your basal cell carcinoma in the forehead, and then you have this ulcerating nodule present in your lower eyelid, and this is your morphic variety of your basal cell carcinoma. So, this morphic variety of basal cell carcinoma spreads rapidly because they synthesize type 4 collagenase. Now, the risk factors which are for recurrence in the basal cell carcinoma can be classified as low risk and high risk. So, on the basis of your location, right. So, if it is area L and the size is less than 2 centimeter, and it is a low risk, and if it is area L and it is more than 2 centimeter, then it is high risk. Similarly, area M less than 1 centimeter is low risk, and area M more than 1 centimeter is high risk, and area H is your high risk. So, what are these areas H, L, and M? So, if you look over here, area H, these are mask areas of face, that includes your central face, eyelids, eyebrows, periorbital nose, lips, cutaneous and vermilion, chin, mandible, preauricular and postauricular skin, sulci, temple and ear, genitalia, hands and feet. Then you have your area M, which includes cheeks, forehead, scalp, neck, pretibial, and your area L, that includes your trunk and extremities, including pretibial, hands, feet, nail units and ankle. right. So this is your classification of area H, M and area L. So the borders, if they are well defined, then they are low risk, poorly defined, then it is high risk. Then primary versus recurrent. Primary is your low risk tumor and recurrent is your high risk tumor. Immunosuppression, if present, is a high risk. Then site of prior radiation therapy also classifies it to be a high risk, and the nodular and superficial subtypes are your low risk, whereas aggressive growth pattern is considered to be a high risk, and perineural invasion is also considered to be high risk feature. So these are your features which are considered to be your low risk and your high risk. Now coming down to the treatment part, the margin negative resection is the treatment part, and a 5 mm margin is said to be needed for your local disease control, and in your aggressive tumors you might need a wider margin, right. And the treatment modalities include most micrographic surgeries, and for your superficial tumors it would also include your 5-fluorouracil and imiquinone. So this were the few important points with respect to your basal cell carcinoma. The next skin tumor is your squamous cell carcinoma. It is a malignant tumor of keratinizing cell of epidermis or its appendages. It arises from the stratum basilis of epidermis. It expresses cytokeratin 1 and 10. It is your second most common form of skin cancer. It is much more common in male compared to females. It is associated with chronic inflammation and immunosuppression. When squamous cell carcinoma occurs in your previous scar, it is known as your Marjolin ulcer. The risk factors include your ionizing radiation, arsenic compounds, HPV infection with 5 and 16 subtype, and current and previous tobacco use, which almost doubles the relative risk of squamous cell carcinoma. Then there are few entities which needs to be discussed along with the squamous cell carcinoma, like actinic keratosis. Now this is the image of your actinic keratosis. So these are areas of permanent sun damage at which your disc keratosis occurs, partial thickness cellular atypia occurs, and subepidermal inflammation occurs, and the basement membrane is intact. So they wax and wane macroscopically between macular and papular, with and without keratinous surface. They mostly improved after moisturization, but around 20% of them develop into squamous cell carcinoma. So when it has its keratin surface height more than base, then it forms a keratin horn, and 10% of them have a chance of underlying squamous cell carcinoma. So this is an example of your cutaneous horn. So all these images have been taken from your standard textbook Bailey and Love recent edition, which is your 20th edition, right. Now another important entity over here is your keratoancythoma. So if you look over here, this is your keratoancythoma, right. So these are your rapidly growing tumors which are nodular tumors, and they are symmetrical tumors, and they are central keratin filled with crater, right. So this is the central keratin filled with crater. Then they are also referred to as your self-healing squamous cell carcinoma. They occur at the face and limb. Male to female ratio stands 2:1, and they are also associated with your HPV infection, smoking, and chemical carcinogen exposure. Your treatment includes your excision. Then we have Bowden's disease. So what it is Bowden's disease? This is squamous cell carcinoma in situ, right. So we have this image over here which is showing your Bowden's disease, right. So this are full thickness dysplasia in a hypertrophic actinic keratosis. They are slow growing erythematous scaly plaque. Now it occurs at the mucocutaneous surface of the body, and It is known as erythroplasia of Couillard when it occurs at the glans penis. So, this is an example of your erythroplasia of Couillard, right. The topical therapy includes your 5-fluorouracil and imiquimod margin and imiquimod, and your surgical excision would include your 4 mm margin. Then the macroscopic appearance of a squamous cell carcinoma, it will have a characteristic everted edge, right, and the surrounding skin would be inflamed and indurated. The microscopic feature associated with squamous cell carcinoma include irregular masses of squamous epithelium noted to proliferate and invade dermis of basal layer. They also have your keratin pearls, right. Then we have a broader grading for your squamous cell carcinoma. So, grade 1 is when there are 0 to 25% of undifferentiated cells. Grade 2 is 25 to 50% of undifferentiated cells. Then grade 3 is your 50 to 75% of your undifferentiated cells, and grade 4 is 75 to 100% of your undifferentiated cells, right. So, these are some of the examples of your squamous cell carcinoma images which have been taken from your Bailey Love. Now, regarding the risk factors for your local recurrence from metastasis and squamous cell carcinoma. So, we have this location and this size, and area L less than 2 centimeter and area M less than 1 centimeter, area L more than 2 and area M more than 1 centimeter, and the area H, which is your mask area, is your high risk, and this on the other hand area L less than 2 and area M less than 1 centimeter is your low risk. Then if the borders are well defined, it is low risk, whereas a poorly defined borders are your high risk. A primary tumor would be a low risk and a recurrent tumor will be a high risk. No immunosuppression, presence of immunosuppression makes it a high risk. Then a rapidly growing tumor is a high risk, and a site of prior radiation therapy or chronic inflammatory process makes it a high risk. Neurologic symptoms also makes it a high risk. Then the degree of differentiation, a poorly differentiated is a high risk, whereas a well or a moderately differentiated is a low risk. Then we have this desmoplastic or metaplastic subtypes or ankylosing or adenosquamous subtype. Now they make it again a high risk, and perineural lymphatic and vascular involvement also makes it a high risk, and the depth more than 2 mm makes it your high risk lesion. You have your surgical excision where less than 2 centimeter, a recommended margin of 4 mm, and more than 2 centimeter we have a recommended margin of 1 centimeter. Now this is a TNM classification of your squamous cell carcinoma. Since it's giving in your Bailey and Love, we are discussing it over here. So please just pay heed to some important points. The T staging, you have your T3, which is your primary invasion of your facial bone. T1 is less than 2, T2 is more than 2 centimeter, and when the base of skull is involved or a muscle is involved, that is your T4. Now regarding your nodal involvement, when it is a spread to a node that is less than 3 centimeter in diameter, it is your N1. N2A is an ipsilateral nearby node that is 3 to 6 centimeter in diameter, and N2B is spread to more than 1 ipsilateral nearby node, but none is more than 6 centimeter in diameter. Then we have N2C, which is spread to a contralateral node, but none are more than 6 centimeter in diameter, and N3 is your spread to any node more than 6 centimeter in diameter. So this N node staging would be common to a lot of TNM stagings, which we shall be discussing in one of the videos lectures, which would be your TNM classifications in the latter part of this classes, right. And then we have your metastasis, which is M0 no metastasis, and M1 your metastatic disease present. So these are all your important one-liners that can be asked from your squamous cell carcinoma. The next skin malignancy that we have is your cutaneous malignant melanoma. So this is a cancer of melanocytes. It arises in your skin, mucosa, retina or leptomeningeal. It is the most likely cause of your cancer death, and it is the most commonest cancer in your young adults aged between 20 to 39 years. Now the cumulative UV exposure is responsible for your late onset of disease, and it is usually leading to your lentigo malignant melanoma variant, whereas your flash fry exposure leads to your early onset of disease and is responsible for your other variants apart from your lentigo malignant melanoma. The various risk factors for your malignant melanoma includes your genetic syndrome, past history of malignant melanoma, more than 30 sun acquired nevi, history of 5 significant sunburn before the age of 16, and fair skinned or red haired people living closer to equator. Then excessive UV exposure and immunosuppression are some other risk factors. Now in women with higher socioeconomic status, it has been noted that there is a positive correlation with the developing melanoma. Then what are the macroscopic features in nevi which suggestive of malignant melanoma? So this is an important box from your Bayesian law. It includes your change in size, shape, color, thickness, that is elevation, nodularity or ulceration. Then your satellite lesion, which includes your pigment spreading into the surrounding areas, tingling, itching and serosanguinous discharge usually late signs. Right. Now the various subtypes of melanoma. So this we have is a superficial spreading melanoma. Now this is your most common presentation, and if there is a nodularity within this superficial spreading melanoma, that signifies the onset of your vertical growth. Then the next image that we have is of your nodular melanoma. It is more aggressive compared to your superficial spreading melanoma. It has a shorter clinical onset. It is much more common in men compared to women. It is more commonly seen in your middle age group. It is seen in head, trunk and neck. They present as blue or black papules measuring 1 to 2 cm in diameter, and they lack a horizontal growth phase. So these are your few important points with respect to your nodular melanoma. Then this image is your lentigo malignant melanoma, the same which is responsible because of cumulative UV exposure and has a late onset of disease. Now this is also known as your Hutchinson melanocytic freckle. It is a slow growing variegated brown macule on face, neck, hands of elderly, more common in women compared to your men. Then it has a less metastatic potential and it takes longer to enter your vertical growth phase. Right. Now this is another variant of melanoma, which is your acral lentiginous melanoma. So this is very rare in white skin. It usually affects the soles and palm. It consists of a flat irregular macule in your later life. Around 25% are amelanotic, right, and they may mimic a fungal infection or a pyogenic granuloma, right. And the malignant melanoma under fingernail is actually a superficial spreading melanoma, right. So please do not confuse it with your acral lentiginous melanoma, which mainly affects the soles and the palm, and the malignant melanoma under the fingernail is your superficial spreading melanoma. Then the classical feature of your subingual melanoma is your Hutchinson sign. So what is this Hutchinson sign? So you have this nail fold pigmentation that widen progressively to produce a triangular pigmented macule that is associated with nail dystrophy, right. And the prognosis is dependent upon the lymph node metastasis and your Breslow thickness. The management would include your sentinel lymph node biopsy and excision biopsy with 2 to 3 mm margins. In case of melanoma in situ, we have a margin of 5 cm. a 1 centimeter margin if it is less than 1 mm deep, and a 2 centimeter margin if it is more than 1 mm deep. Now, in case of stage 4, we go for a targeted therapy, and this targeted therapy is to block your BRAF mutation, which is in your V600 codon. Now, the most important two drugs which I would want you all to remember is your dabrafenib and vemurafenib, right. So, these are your targeted therapies for your malignant melanoma, which blocks your BRF mutation. Now, regarding your staging of your malignant melanoma, we have your T1 staging, right, which is A. T1 in general is less than 1 mm. T1 A is 0.8 mm with no ulceration, and T1B is 0.8 to 1 mm with no ulceration, or less than 1 mm with ulceration. T2 is size from 1 to 2 mm. A is no ulceration and B is present with ulceration. T3 is size 2 to 4 mm. Again, A with no ulceration and B with ulceration. T4 is size more than 4 mm. A with no ulceration and B without ulceration. Then we have this nodal staging. N is one node present, where we have your micrometastasis, macrometastasis and presence of satellite lesion, that is 1C. In case of N2, we have 2 or 3 nodes present. Again, 2A would be metastasis, B will be macrometastasis and C will be MSI present. In case of N3, we have micrometastasis in more than 3 nodes. In B, we have micrometastasis in more than 3 nodes or 1 clinical or matted or 1 clinical node, and there is no MSI. In N3C, we have more than 1 clinical or occult node with MSI present. MSI is your satellite nodule. Then regarding your M staging, M1A is your skin or subcutaneous or distant lymph node metastasis, M1B is your lung metastasis, and M1C is your all other visceral metastasis or any distant metastasis with elevated serum LDH level, right. So, lung metastasis with a normal serum LDH level, whereas if it is an elevated serum LDH level, then it would be your N1C, and N1D is your brain metastasis, right. So, if a question has to be framed from the TNM staging of your malignant melanoma, there are high chances that they would be framing it from the M part. So, remember, LDH is elevated in C, lung is B and brain is D, right, and 1A would be your skin, subcutaneous tissue or the distant lymph node metastasis, right. And then the last important skin malignancy with which we end our topic is your Merkel cell tumor. It is most commonly seen in elderly, a malignant tumor of your Merkel cell. It is much more common in women compared to male, and the treatment includes your wide local excision with 2.5 to 3 centimeter margin followed by radiotherapy.